Bismillahirrahmanirrahim. Assalamu alaikum everyone. Today presenting a topic of treatment of testicular cancer, Seminoma. My name is Dr. Vipula Baloch, moderator Dr. Irfan. There is epidemiology and background. The most common solid malignancy in males age is 15 to 13, 5 years. Global incidence rising is 95% of all testicular tumors are germ cell tumors. Bilateral presentation in 2% of cases, exceptional prognosis. Pathology overview. Pure seminoma, cellular uniformity, large round polygonal and lymphatic infiltrate invasion and placental alkaline phosphate positive in 95 to 100%. Serum markers AFP never elevated, beta HCG elevated 15%, LDH proportional to bulk. TNM staging already present in last previous lecture. IgCCG prognostic classifications. There are two groups. One is good risk groups, another is the intermediate risk groups. Good risk groups.
Actually, there are three groups in the IgCCG classification: the good, the intermediate, and the poor. However, seminomas, the poor group does not apply. It's only the good and intermediate risk. Okay, so go on.
Good risk groups is primary site any, visceral mets, no non-pulmonary, markers any SCG, any LDH. 5 years progression free survival is 89% and 5 years overall survival is 95%. Intermediate risk groups, primary site any, visceral mets, liver, bone or brain, markers any SCG, any LDH. 5 year progression free survival is 79%, 5 years overall survival is 88%. Stage 1 overview. Tumor confined strictly to the testes, red testes, no evidence of nodal or distant mets. Cure rate is 100% with appropriate management. Most common presentation is 75 to 80% of all seminoma. There is post-orchidectomy management strategies. There is active surveillance, adjuvant carboplatin, and adjuvant radiotherapy.
Okay, just to clear the concept again, we've been talking about active surveillance a lot lately. Kayum, can you tell me what active surveillance means, what as compared to watchful waiting? Active surveillance.
We monitor the disease for the extent of treatment. Our main goal is in the future the patient needs treatment.
Okay,
But
and when watchful waiting,
watchful waiting, patient have multiple co-ops and we can symptomatic treat the patient.
Okay. So the main difference between active surveillance and watchful waiting is the intention. हमारा मकसद क्या है? In watchful waiting, we are only trying to make the patient's symptoms better. We are not going to offer a cure. Okay? For example, in active surveillance, you are going to offer a cure. You're not going to do anything at the start, but if the disease progresses, you're going to go for a cure. Okay, so that is the biggest difference. In watchful waiting, you do not go for a cure. You only palliate the symptoms. And the main determinant of active surveillance versus watchful waiting is the life expectancy. Okay, so if you have a life expectancy of more than 10 years, then you have a good functional status, then you are a candidate for active surveillance. Else, you go for watchful waiting. Okay? Let's go.
Stage 1 risk stratification. Tumor size more than 4 centimeters, red testis invasions, and relapse risk on surveillance. There are low risk 4% and high risk 15.5 to 22%. Stage 1 active surveillance option 1. EUA prefer options. Standard of care for stage 1 to minimize our treatment. 5 years relapse rate is 12 to 20%. Salvage rate is 99 to 100%. Primary benefits: avoid long-term toxicity of chemoradiotherapy and require strict patient compliance and enable high quality imaging.
Okay, so it's very important. Okay, it requires strict patient compliance and accessible high quality imaging. So compliance is one of the most important things in this scenario, especially in our setup, because all of our patients do not come from Karachi. Even the ones from Karachi do not regularly follow up. This requires a very strict regular follow-up so that it can be used. यहाँ पे ना लिखा है 99 to 100% salvage rate. Can anyone explain to me what 99 to 100% salvage rate means in that when we're talking about a tumor? Qayyum, Amir,
Salvage rate, I think the patient is disease free.
but that's the disease-free survival. That's the disease-free survival rate, no? Salvage rate क्या है? Salvage rate means that if the primary treatment has failed and you do a secondary treatment, after that secondary treatment, the patient is cured. Okay? That is salvage rate. So it means that if the primary treatment has failed and you go for a secondary treatment after the primary treatment, and if that treatment succeeds, then it is considered as a positive salvage rate. Okay?
Stage 1 adjuvant carboplatin, option 2. Standard regimen single cycle carboplatin, area under curve 7 post orchidectomy.
Now, these are the three trials that have shown the efficacy of a single dose of carboplatin in patients with stage 1 testicular cancers. We have the MRTC trial, the Swinotica trial, and we have also another trial that we're going to be talking about later on, the SCAN trial. And the NCCN recommendation is a category 1 status which reduces contralateral metapronous germ cell tumors. Area under curve, as you can see, area under curve is a very fancy term of saying that we're not going to look at the dose, we're going to look at the exposure that we're giving to the patient. And the dose is calculated on the exposure of the patient, not just the creatinine clearance and half-life of the dose. Okay?
Stage 1 adjuvant radiotherapy, option 3. Historical context and protocol, standard of care historical primary management for decades due to excellent local control. Technique periodic irradiation, efficacy reduced lapse rate to 3 to 4%. Secondary malignancy relative risk increased to 2 hour time, cardiovascular toxicity, gastrointestinal toxicity.
As you can see, the relapse rate in radiotherapy is much less than the others. One was 4 to 12%, and the other one was, I think, 3 to 9%, but this is 3 to 4%. So why are we not using the radiotherapy? And if you do look at our books, you're going to see a very beautiful line. It's written, a seminoma is exquisitely radiosensitive. Yeah, you guys remember that, right? It's exquisitely, very beautiful word used. So why are we not using radiotherapy for seminomas? Yes, because it's too much. We're over-treating the patient. Okay? The side effect, what are the main side effects? What are the most dangerous side effects that we are fearing in a patient that we're treating for radiotherapy in seminoma? Yes, secondary malignancy. Treating one thing and then 5 years later finding out that the patient has a secondary malignancy due to our treatment. When we have other options and we know that a salvage rate of almost 100% is available anyways, it means very aggressively over-treating a patient. Okay?
EAU and CN recommendation stage 1. EAU guidelines Act 2024 active surveillance prefer management for all stage 1 patient. Adjuvant carboplatin 1 cycle for high risk patient unwilling to undergo surveillance. NCCN guidelines 25 observation prefer management, and carboplatin adjuvant single agent carboplatin is a category 1 recommendation. Radiotherapy listed at category 2B lower concession for stage 1. Stage 1 follow-up schedule. Year 1 and 2 every 3 to 6 months.
If you go to the last slide, if there is a MCQ on this scenario, and if there is something written that the patient lives in Urology or some place where the patient cannot follow up, so preferred management जो है वो change होके adjuvant carboplatin पे आ जाएगी. So when you are solving those MCQs, you have to use your brain properly and have a good IQ and alertness over there, that there are some hints given in every MCQ. There is one aspect which is very openly given and one aspect is hidden in that. I'll give you an example. There was a scenario in FCPS Part 2 exam that the patient has got stone disease, Staghorn stone, and the patient was diabetic and hypertensive, or what will be the management? How will you follow up the patient? Everyone wrote, we'll give therapy to prevent stone, this, that. Nobody focused on BP and diabetic as well. So one line or one thing in that written question, if you would have written that we will control the blood pressure of the patient, we'll maintain the diabetes under control and everything. So there's one hidden aspect as well, one open aspect. So there is a hint given in that MCQ. So if it is a normal patient, you will go for active surveillance, which is preferred. But if it is written that patient has come from far-flung area and all, and if you write active surveillance in that patient, so that MCQ will be wrong. So
Thank you, sir.
Okay, thank you, sir. Stage 1 follow-up schedule. Year 1 and 2 every 3 to 6 months. Year 3 every 6 months. Years 4 and 5 annually. More than 5 years, consider continuous surveillance for late relapse.
So basically, more than 5 years is up to the physician itself. So if some physicians prefer 6 monthly and some physicians prefer 1 yearly. It's up to the discretion of the physician after 5 years. And chest X-ray is done every year. Okay, so once again we want to minimize radiation. We're not going to do the chest X-ray every 3 months on the patient. We're going to do it every year. However, tumor markers are to be seen at every visit. Okay, that is very important. Every visit, tumor marker. A chest X-ray every year. Every visit has to be seen, has to be followed by a tumor marker. Okay, next slide.
Stage 1 special consideration. Anatomical variation. Bilateral tumor manage each side independently based on stage and risk factor. Solitary testing consider organ sparing surgery for masses less than 2 cm if feasible. GCNIS management contralateral biopsy recommended for high risk patient.
Sorry. So GCNIS means germ cell neoplasia in situ. Okay.
Contralateral biopsy recommended for high risk patient, age less than 40, volume less than 12 ml. Cryptorchidism management of GCNIS observation with local radiotherapy 18 to 20 gauge. Clinical risk history. Cryptorchidism high baseline risk for GCNIS and long-term surveillance. Increased risk of GCNIS in the contralateral and cryptorchidism and undescended testes. Leading cell function. Preservation of endocrine function is a key survivorship goal. Provide hormone replacement therapy if the patient becomes testosterone deficient post-treatment.
And we're not talking about post-treatment. We're also talking about pre-treatment. The concept of sperm banking has become very widely accepted now. And before starting chemotherapy, patients are encouraged to do sperm banking. Okay.
Stage 1 outcome summary. Active surveillance labs 15 to 20%. Adjuvant carboplatin labs 4 to 9%. Adjuvant radiotherapy relapse 3 to 4%. Key takeaway, all approaches achieve 99 to 100% overall survival. Stage 1B with Stage 1A distinction. Stage 1A, tumor limited to testes, no lymphovascular invasion, tumor size less than 4 cm, no rate testes invasion. Stage 1B, PT2, lymphatic vessel invasion or epidermal invasion, PT3, spermatic cord invasion, PT4, scrotal wall invasion, tumor size more than 4 cm often associated. Clinical management follow-up application. Stage 1A focus generally managed with active surveillance, lower risk of relapse. 4% allow for standard follow-up protocols. Stage 1B focus EIU recommend adjuvant carboplatin due to higher relapse risk, require intensive follow-up if surveillance is chosen. Stage 1 key clinical trials.
So these are the three clinical trials that have been mentioned here. The most important is the SAC one, which has defined that a long-term outcomes of active surveillance show that confirmed 99 to 100% overall survival despite 15 to 20% relapse rate. Once again, active surveillance does not mean that you're not going to treat the patient. Okay, you're not. A stage 1 disease has 100% salvage rate. Salvage rate का मतलब ये है कि if you've tried one method of treatment and that method has failed and you go for secondary treatment, it succeeds in 100% of cases. That is the meaning of salvage rate. Okay. So let's go next.
Stage 2 overview. Definition seminoma with metastatic spread to the retroperitoneal lymph nodes. Stage 2A, N1 disease, nodes less than 2 cm. Stage 2B, N2 disease, nodes 2 to 5 cm. Stage 2C, N3 disease, nodes more than 5 cm. Prognosis more than 95% cure rate, highly curable with standard of care protocols. Primary modality radiotherapy preferred historically for 2A. Chemotherapy, bleomycin, etoposide cisplatin, and etoposide cisplatin preferred for 2B and 2C. Choice based on substage and disease bulk. Stage 2A seminoma management option. Definition N1 disease, retroperitoneal lymph node less than 2 cm. Radiotherapy, standard para-aortic plus ipsilateral iliac dog leg fields, dose 30 graveyard in 1.5 to 2.0 graveyard fraction. Efficacy, relapse-free survival 92 to 95%. Chemotherapy regimen.
Sorry. So the most important part of this slide is the long-term concerns of radiotherapy. Okay. Which would be secondary malignancies, cardiovascular, and GI toxicities. Okay. We're going to move to the second slide for chemotherapy. And it says that it's preferred if markers are positive or for systemic control. Can anyone tell me for a seminoma, what are the tumor markers that we'd be looking for? Sorry? Yes. Are we going to look only for a beta HCG? And LDH. So what is no AFP? Raise your hands if you think we should look for AFP. No one? Very good. So yes, a seminoma does not exhibit any AFP secretion. However, the LDH is what we call a representation of the tumor burden inside the body. Okay, it is not specific to the seminoma, but it signifies the burden of the tumor inside the body. Okay? Let's go next.
Stage 2B seminoma. Retroperitoneal lymph node 2 to 5 cm and 2. Radiotherapy protocol 36 graveyard to dogleg field, para-aortic plus ipsilateral iliac. Historical standard of care, relapse rate is 10 to 15% higher than 2A. Concern long-term GI and cardiovascular toxicity. Chemotherapy standard regimen, bleomycin, etoposide cisplatin into 3 cycles or etoposide cisplatin 4 cycles. Addressing systemic micrometastasis more effectively. Lower relapse risk compared to radiotherapy in 2B. NCCN category 1 recommendation. Stage 2C seminoma, bulky disease management. Nodal mets with largest dimension more than 5 cm and 3 disease. Standard treatment protocols. BEP to 3 cycle standard for good risk. If etoposide cisplatin 4 cycle, if bleomycin is contraindication. EAU and NCCN 2024 cisplatin based chemotherapy mandatory. BAP chemotherapy regimen detailed. Bleomycin, etoposide cisplatin. Bleomycin administered day 1, 8 and 15. Etoposide day 1 and 5. Cisplatin day 1 and 5.
1 to 5.
1 to 5. Clinical crucial monitoring, pulmonary baseline and periodic PFT pulmonary function test, top bleomycin toxicity, renal creatinine clearance and hydration status for cisplatin nephrotoxicity, hematologic CBC monitoring for myelosuppression. Etoposide cisplatin chemotherapy regimen detailed. Etoposide day 1 to 5 and cisplatin day 1 to 5. Indication for etoposide and cisplatin, our bleomycin, etoposide, cisplatin, prior pulmonary disease, age more than 40 years, active heavy smoker, high bleomycin risk. Toxicity side effect, renal nephrotoxicity, neurological neurotoxicity, hematological myelosuppression, and long-term secondary leukemia. Stage 2 radiotherapy technique. Target volume, standard field, para-aortic strip plus ipsilateral iliac nodes. Dogleg will extend to the inguinal region on the side of the primary tumor. Dosing protocol: stage 2A 30 graveyard, stage 2B 36 graveyard, fractionation 1.8 to 2.0 graveyard per fraction. Deliver daily Monday to Friday. Stage 2 outcomes and follow-up. Standard follow-up schedule: year 1 and 2 every 3 months, year 3 and 5 every 6 months, more than 5 years annual, symptom based. Every visit will repeat a tumor markers. Stage 3 overview: advanced metastatic disease. Involves distant mets beyond the retroperitoneum. Stage 3A distant lymph node metastasis supraclavicular mediastinal. Stage 2B non-pulmonary visceral metastasis. Stage 3B non-pulmonary visceral metastasis liver, bone, brain, intestine. Standard staging includes CT chest, abdomen, pelvis plus serum marker. Good risk and intermediate risk. Any primary side, no non-pulmonary visceral metastasis. Up to 5-year overall survival 95%. Intermediate risk: presence of non-pulmonary visceral metastasis. 5 years overall survival 88%. Stage 3 good risk: IGCC International Germ Cell Collaboration Group. Prognostic criteria: primary side, any primary side, testicular or retroperitoneal. Metastasis: no non-pulmonary visceral metastasis, no liver, bone or brain. Markers: any LDH, any HCG, alpha beta protein must be normal for pure seminoma. Standard treatment: bleomycin, etoposide is 3 cycle, bleomycin, etoposide plus, and etoposide is 4 cycle. Stage 3 intermediate risk. Classification criteria: any primary side, testicular or extragonadal. Non-pulmonary visceral mets, liver, bone, brain. 2021 update: LDH more than 2.5 is an advanced.
It's 2.5 times the upper normal limit because every lab has different upper normal limits for LDH. So the consensus is the upper normal limit of the LDH value of the lab. If it's more than 2.5 times that, then you're going to consider it. Okay.
Standard chemotherapy regimen: 4 cycle of BEV, mandatory for intermediate risk, standard of care. Site-specific management: brain met, bone met, and supportive care monitoring. Stage 3 treatment response monitoring. Standard CT chest, abdomen, pelvis. Timing: perform after 2 cycle of chemotherapy. Assess for early response or disease progression. Serum markers: AFP, vitality, and LDH. Frequency measure at every cycle. Marker decline is critical for prognosis. Complete response, partial response, and progressive disease. Stage 3 special situation. Organ specific metastasis: brain, whole brain, RT concurrent with back 4 cycles. Liver: systemic chemotherapy is the preferred primary approach. Bone: systemic chemotherapy, palliative radiotherapy after chemo for pain or fracture prevention. Fertility preservation: urgent sperm banking must be complete before initiation of chemotherapy. Discuss potential for permanent infertility and the role of testosterone replacement if leading cell function is compromised. High risk scenario: very high risk scenario require intensive monitoring or upfront marker decline. Emergency chemotherapy initiated immediately for rapidly progression or systematic disease. Role of surgery: the role of retroperitoneal lymph node dissection is significantly limited in stage 3 seminoma. Primary reserve for PET positive residual masses more than 3 cm after completion of chemotherapy. Stage 3 outcome tables. Complete response 75 to 80%. Good risk, intermediate risk is 65%. Up to 5-year progression-free survival, good risk 89% and intermediate is 79%. 5 years overall survival, good risk is 95% and intermediate risk is 88%. Stage 3 post chemotherapy assessment. Standard evaluation protocol. Timing: CT chest, abdomen, pelvis 4 to 6 weeks after last cycle. Marker mandatory serum marker, AFP, SCG, and LTH at each evaluation. Complete response, total resolution of mass, or all residual mass with negative markers. Progressive disease, growth of existing lesions or new lesion requires salvage regimen. Role of PET-CT recommended specifically for residual masses more than 3 centimeter at more than 6 weeks post chemotherapy. Stage 4 definition and overview. Anatomical definition: distant metastatic disease extended beyond the retroperitoneum and regional lymph nodes. Common metastatic sites: lungs, brain, bone, liver. Seminoma has no poor risk category. Stage 4 corresponds to 3B and 3C groupings. Visceral non-pulmonary involvement dictates intermediate risk. Stage 4 first line chemotherapy. Good risk. BAP 3 cycle standard of care. EP 4 cycle is if bleomycin is contraindicated. Intermediate risk, BAP 4 cycle. Seminoma has no poor risk category. Intermediate risk include non-pulmonary visceral metastasis. Stage 4 role of surgery. Post chemotherapy residual mass only if PET-CT remain positive after more than 6 to 8 weeks. Isolated metastasis resection considered on a case by case basis. Post HGC EAU recommends surgery for PET positive residual masses. Stage 4.
Sorry, Pichi. Now, the technical challenges after the chemotherapy is that there is desmoplastic reaction, there is surgical morbidity because the patient has received chemotherapy, and the patient after receiving chemotherapy, especially BEP4, the patient's clinical and functional status is not the same as it was pre-chemotherapy. So that plays a role itself, and expertise is required. Sorry.
So one more challenge, according to my own understanding of from the angle of oncofertility, is to translocate testes from the scrotum. So in many of the instances, yes, chemotherapy regimens, they have got a systemic effect on the potential of a sperm to be more mobile and active in its own function. But more so, the germinal epithelium needs something which, if it is in the line of radiotherapy. So if you are planning radiotherapy to the scrotum, then the surgical team has to be very much conversant with whatever the ways by which you can take away the testis away from the scrotum. Because this is very simple. Everybody in this audience, in this hall, knows how to do radical orchidectomy. The same incision is given in the inguinal region. The whole testis is mobilized and it is delivered out of the inguinal region, a small incision. And then it is placed either in anterior compartment of the thigh or maybe over the anterior abdominal wall, away from the field which you have described as a dog-leg field or whatever the field is, which is proposed by the radiation oncologist. So one has to work in collaboration with the radiation oncologist, and the surgical team has to know where to put the testis, because in many of the instances, the surgical team is not actually in the process of thinking that they have got a very big role in protecting testis, not only from the potential of chemotherapy, but also from the protection of radiotherapy, right? So this is one thing. The second thing is whenever the things get settled and the patient is 100% cured, that testis can again be placed down there in the scrotum again. So it's a very simple job. It's a very simple job, but it has to be understood. So once you understand it, then you can do it, and the patient will be as normal as anyone.
Thank you, sir.
And talking about PET scans, so this is one of the main or only indication of performing a PET scan in a seminoma patient with these things happening. Because whenever we discuss with our junior residents and junior consultants, they have in mind that if this is a non-seminomatous germ cell tumor, then also we will perform PET scan. So in that case, I guess we'll be discussing that later on. So you have to perform RPLND in those cases. So there's very less indication for PET scan. But in seminoma, This is the main indication of PET scan. If anybody asks that, what is the one single best investigation for seminoma in deciding the role of surgery post orchidectomy? So this is the indication for PET scan.
Thank you, sir.
Stage 4 brain mets management. Radiotherapy is standard concurrent with chemotherapy. For solitary and oligometastatic disease. Chemotherapy BAP4 standard systemic backbone. Intrathecal rarely utilized in pure seminoma. Supportive care, corticosteroids essential for peritumoral edema. Surgery resection for selected accessible cases. Stage 4 outcomes and prognostic factors. Good risk 95%, 5-year overall survival. Intermediate risk 88%, 5-year overall survival. Residual masses introduction. Highly common post chemotherapy due to significant dermoplastic reaction and fibrosis. Unlike NSGCT, teratoma is not a concern in pure seminoma. Histology primarily reveals necrosis or dense fibrosis rather than active malignancy.
That is why we use a PET-CT for masses of more than 3 centimeters to determine if it is something which needs to be addressed or not.
PET-CT in residual masses. Indicate standard of care for residual masses more than 3 centimeter. Optimal timing, perform minimum 6 weeks, ideally 8 weeks after the last cycle of chemotherapy to minimize false positive from inflammation. Diagnostic value 100% and 8.7%. Residual masses management algorithm. Residual masses less than 3 centimeter post chemotherapy seminoma. PET negative active surveillance. Residual masses more than 3 centimeter. PET CT at more than 6 to 8 week post chemo. PET negative develop 1 to 2 surveillance. PET positive develop biopsy resection salvage. Timing is crucial. PET before 6 weeks yields high false positive rates due to inflammation. Equivocal recommends repeat PET CT in 6 to 8 weeks before intervention. Refer all resection of residual masses must be at high volume specialized center. Residual mass surgery. Technical consideration. Intense dermoplastic reaction, significant fibrosis makes dissection more difficult than an NSGCT. Vascular adherence, high risk of adherence to aorta and IVC. Specialized care referral to high volume centers mandatory due to complexity. Surgical approach, open laparoscopic or robot assisted RPLND in selected cases. Potential complication, vascular injury, chylous ascites, retrograde ejaculation, and urethral injury. Residual masses follow-up after management. Surveillance schedule, PET negative observation. Year 1 and 2, CT abdomen pelvis every 6 months. Year 3 and 5, annual CT imaging. Tumor marker FBHCG at every visit. Histology-driven viable tumor post-resection requires consideration of salvage chemotherapy. Late recurrence management, recurrence more than 2 years is rare if suspected. Full restaging CT, chest, abdomen, pelvis plus marker biopsy of accessible lesion. Recurrence overview, classification by timing and sequence. Early relapse first and second relapse during surveillance or post first line chemo. Late relapse more than 2 years from complete remission. Very late relapse more than 5 years, incidence 0.5%. Comprehensive diagnostic workup, imaging CT, chest, abdomen, pelvis, identify nodal or visceral spread. Bone scan if patient is symptomatic for bone pain. Biochemistry serum marker, mandatory testing for AFP, SCG and LDH. Not AFP elevation suggests non-seminomatous component. A specialized workup, biopsy, strongly consider for accessible lesion if diagnosis is uncertain. PET CT useful for equivocal residual or recurrent disease. Recurrence after surveillance stage 1. Relapse profile 12 to 20% relapse rate. Primary site, most relapse occur in the para-aortic lymph nodes, usually detectable by scheduled CT scan. Salvage strategy, chemotherapy, BAP3 good risk, BAP3 4, BAP into 4 bulky intermediate radiotherapy considered for isolated non-bulky nodal relapse retroperitoneum only. 100% salvage rate. Recurrence after first line chemotherapy. Incident rate 10 to 15% recurrence after BEP for advanced seminoma. Key prognostic factors: prior response, duration of complete remission, anatomic site of relapse, serum LDH level. Early relapse less than 3 months, poor prognosis, conventional salvage often insufficient, high dose chemotherapy recommended. Late relapse more than 2 years may be chemosensitive or resectable, requires thorough re-staging and biopsy. Salvage regimens detailed protocol. Paclitaxel, ifosfamide, cisplatin, 4 cycle every 21 days. Vinblastine, VAP regimen, vinblastine, ifosfamide, cisplatin, 4 cycle standard salvage. High dose chemotherapy and ASCT clinical indication. Second, relapse or cisplatin refractory disease, early relapse less than 3 months after first line therapy, refractory to conventional salvage regime, standard protocol, C and C regimens, carboplatin plus etoposide, ifosfamide, tandem HDCT, 2 sequential cycles with stem cell rescue, TINC protocol standard for approach Indiana and MSKCC and autologous stem cell transplant for recovery. Late relapse and special recurrence scenario. Late relapse more than 2 years, surgical resection, primary strategy if mass is resectable. Chemosensitive often preserve cisplatin based regimen still viable. Marker negative biopsies essential to confirm histology. Very late relapse more than 5 years, incidence 0.5%. Site specific management, brain meds, whole brain RT, concurrent salvage chemotherapy, retroperitoneal only consider radiotherapy for isolated nodal relapse if prior chemo. Refractory cases, somatostatin receptor imaging, not PET CT is used for equivocal residual disease. Treatment algorithm summary. Stage 1, active surveillance preferred by EIU and NCCN guideline. Carboplatin, area under curve 7, 1 cycle for high risk. Radiotherapy falling out of favor. Stage 2A, 2B, radiotherapy and chemotherapy. Stage 2C, 3 and 4, good risk. Bleomycin, etoposide cisplatin, 3 and etoposide cisplatin to 4. Intermediate risk, bleomycin, etoposide cisplatin 4. The key takeaway and guidelines summary. Stage 1 management, active surveillance preferred option for all patients to avoid our treatment. Adjuvant carboplatin single cycle area under curve for high risk size more than 4 cm, red testis invasion. Radiotherapy no longer recommended first line due to long-term toxicity. Residual recurrence, residual masses, PET CT mandatory for masses more than 3 cm, weight more than 6 to 8 weeks for post chemo. Salvage TIVIV regimen, high dose chemo HDCT for refractory cases. Advanced disease 2 to 4. Bleomycin, etoposide cisplatin backbone standard for good risk 3 cycle and intermediate risk 4 cycle. Stage 2 trend, chemotherapy increasingly prefer our radiotherapy for stage 2B. IG, CCG, note there is no poor risk category for seminoma.
Any questions?